Hello, everyone. I am Dike Ojji. I'm a professor of medicine and preventive cardiology at College of Health Sciences, University of Abuja, Abuja, Nigeria, and also happen to be MPI for a number of NIH-funded implementation science research work. I'll be speaking on a scale in the real world case study with emphasis on people, politics, and power dynamics. I will follow in this outline, starting with an introduction and ending with navigating power dynamics in NCD scale up. In a form of background, why vertical biomedical intervention dominated the practice of global health since the late 1980s, there's been in recent years a renewed push for increased power sharing, upwards accountability, and a more reflexive and deliberate way of working towards health for all. So it's an all-inclusive approach now. That is the paradigm shift. Now, this paradigm shift towards greater horizontality in planning and decision making within global health efforts is partly in response to the growing awareness of health inequities and social determinants of health, which is caused across the globe, but maybe more in society like ours or in low and middle income countries. In tackling the issue of people, politics, and power dynamics in scaling up NCD intervention in real world setting, there is actually no recipe book to follow or model that can be brought to scale. We have to learn from experience of other people. We have to learn in interacting with people, in interacting with different stakeholders. However, one important thing is that if done with openness within the otherwise Eureka world of global health research, it has a potential to be a positive force for a change. So the key word there is openness. I'll start off with policymaker. So why policymaker engagement matters for scale up is listed here. Number one is instrumental part of stakeholder and community engagement. Number two, it is an effective approach for translating evidence to practice. Without engaging policymaker, without engaging the government, our result can never be translated to practice. Engaging them enhances knowledge and practice dissemination. Remember that in most cases, they control the media, they control the media in that country. So engaging them can be a great way of disseminating your information or results. Lastly, it's an opportunity to meet partners where they are. Policymakers never love researchers that work in silos. They want researchers to collaborate with other people who are working in similar fields. There are some top tips for engaging policymakers by the Global Alliance for Chronic Disease. Number one is to collaborate with other researchers for stronger policy influence. Number two, you have to speak their language to deliver impactful research communication. The policymakers likely will not read your fanciful publication in the New England Journal of Medicine or JAMA, but they will read some of those your policy briefs. They will read some reports from your meeting proceedings. It is good to start early when building relationship with them. It is good to maintain relationship with them for lasting impact. So don't just collect later support from them and then after that they don't see you. You have to maintain that relationship with them. You have to think like a policy maker. Their drive is towards community approach. Their drive is towards larger impact. We have to think like them. The context matters, so make your research timely and relevant. What is the policy drive of the government? Is the government trying to integrate hypertension, for example, into primary healthcare setting in that country? Key into that policy drive. Actively engage them every step of the way. So at inception or conception, at the formative stages, when interventions start midway into the intervention, and also at the end of intervention. Then engage policymakers across department ministries and sectors. Remember that health is very, very holistic. So it is not just the Federal Ministry of Health that should be engaged. There can be some other relevant agencies and organizations that should be engaged. In this next slide, I want to share some of our examples on how we've tried to, in our implementation science work, to engage policymakers, starting engaging them early when building relationship and also maintaining relationship. So starting early and maintaining relationship is shown by these two pictures. On the left of your screen is a visit of our team at the Cardiovascular Research Center to the then NCD coordinator in the Federal Ministry of Health. Now, this NCD coordinator was quite good, quite receptive, quite supportive of our work. That is a lady in the middle. But our tenure was shortly because she was promoted to the position of what we call a permanent secretary, which is the highest you can hold in public service in Nigeria. And so within about 8 months, there was coming on board of another NCD coordinator, Dr. Ojji Mohammed. Now, we had to be sensitive to make sure that we continue our relationship, even though we visited her like 3 months before she exited, our position. We have to be conscientious also as a team to try and visit the new NCD coordinator for continuity. So start early and maintaining relationship with this policymaker is very, very important. You should actively engage them every step of the way. So in co-creation of a new study, for example, we've been conceptualizing what we call the market study, which has not come into fruition now, but then we started engaging key stakeholders. Among them are market women. And in our initial work at managing hypertension in persons living with HIV, before we started our intervention at all at the formative stages, we had to engage numerous stakeholders, as you can see on this picture on the bottom right, of the screen. And this was one of our studies also. We call it the enhanced study, which is an intergenerational study, which happens to be within the GACD consortium. In our inaugural meeting, we engage different stakeholders from different ministries, different departments, and in white there is the Deputy Vice Chancellor of my university in charge of administration, who represented the institution in that inaugural meeting. And also in terms of study update, the hypertension treatment in Nigerian study, our sodium study, we have tried as much as possible to update, the policymakers and to be able to share with them some of our results as the study continues. You should think like a policymaker. And like I said earlier, the context matters so very much. So we keyed into the policy drive or the Federal Ministry of Health in our hypertension treatment in Nigerian study. The policy drive is a task shifting and task sharing for control of non-communicable diseases, including hypertension, diabetes, and so on. We also keyed into it in our managing hypertension in persons living with HIV, because we are using non-physician healthcare worker to drive this. Before we commence the hypertension treatment in Nigerian study, in 2019, there was a simplified protocol by the Federal Ministry of Health, which were part of, my team was part of those that developed this protocol. And that is exactly what we are using in both the hypertension treatment in Nigerian study and managing hypertension in persons living with HIV. Now, following the policy drive is also very, very important in like I mentioned earlier, and this is exemplified in the Nigerian Sodom study where in 2019, Nigeria announced its multi-sectoral action plan for non-communicable disease, which included a target to reduce mean population dietary sodium intake by at least 30% by 2025. And this is what we key into in our Nigerian Sodom study. And our result in the Nigerian Sodom study is actually driving a lot of policies, include setting benchmark for Nigerian food. And we're working closely with the Federal Ministry of Health, especially their drug and food safety department. You have to speak their language to deliver impactful research communication. So we've done this through policy briefs and other technical documents, some of them which we have also been able to publish. For example, implementing front of pack nutrition labeling to reduce sodium intake in Nigeria. That's a policy brief on our Nigerian sodium study. And on the MAPI study, we have a policy brief on scaling up the integration of HIV and hypertension program in Akwa Ibom State. Akwa Ibom State is where we are doing our intervention. We have also published our meeting proceeding, and we found the European Heart Journal, Cardiopulse, a very good place to do this around managing hypertension, a person living with HIV, around our sodium studies, even around our hypertension treatment in Nigerian study. And in engaging policymakers, we have also tried to include them in publications as co-authors and acknowledging them. However, they have to indicate interest and meet up with the ICMJE authorship criteria. There is no room for gift authorship. And on your right, there is evaluating diabetes care in primary health care in Abuja, Nigeria, which is a cross-sectional formative assessment. And some of the people listed in this, for example, Deborah Odo and Morenike Ales Oko, are policymakers who are working in the Federal Ministry of Health. Registration of patients in HCN study to the community insurance program has been one of the ways we have engaged, one of the success stories for us in engaging the policymakers in the Federal Capital Territory of Nigeria. We've been able to push through our work to able to get a number of patients registered under the Basic Healthcare Provision Fund for the vulnerable population. And before then, we published a policy brief which we shared with the government on improving hypertension control in Nigeria, early policy implication for hypertension treatment in Nigerian program. Now, engaging people in scale up for NCD intervention can be very complex. And because of the complexity involved in engaging people, it is recommended that instead of a target-oriented top-down approach, it is more rewarding to mobilize community members to participate one in decision-making. We've done that in some of our studies. You saw the co-creation. We saw our managing hypertension in persons living with HIV in our formative stage, in planning the work. Now, in implementation and also in evaluation of these programs, and with the overall aim of empowering people to have a greater control over the decision that most affect their life. And we have seen that when people are involved in our in this intervention, they take in interest, and we see that there is more buy-in and more sustainability of this type of intervention. We have experienced that in our hypertension treatment in Nigerian program, and we're also experiencing that in managing hypertension in persons living with HIV. Engaging people in a scale-up of intervention has to be early and continuous. And this is one of the key things we must realize. There has also be holistic mapping of relevant stakeholders of people, which is very, very important. Knowing key people to engage is very important. And this we experience in the co-creation of a new study, what we call a market study, co-creation with relevant stakeholders, in which we want to evaluate the effectiveness of a multi-component hypertension management strategy across 9 urban markets in 2 mega cities of Abuja, which is the administrative capital of Nigeria, and Lagos, which is a commercial capital, using a type 2 hybrid implementation science design. And in this intervention, we are targeting market vendors because of the sedentary life, because of the time tied up in the marketplace and not having time to, for example, do medical checks like checking their blood pressure, blood sugar, and so on and so forth. And in this co-creation, we are engaging the leading, we engage in leadership of the Market Vendors Association. But since there are different associations, we have to also understand the power dynamics, how we're going to go about it. And how did we do this? We have to speak to people who have worked with them. We have to speak with different leadership. We have to get down to that level, visit them in the marketplaces, and see, and even in the association meeting, and see how things play out. You have to understand this complexity if you want your intervention to be successful. Engaging people at the formative stages cannot be overemphasized, and it can be very, very useful in refining our intervention. I remember our experience in managing hypertension in persons living with HIV, and when we engage the different stakeholders, as you can see, a large number seated, including nurses, community extension workers, persons living with HIV, and so on and so forth. One key thing that came out was that we have to have a way of disseminating the information around checking blood pressure, visiting the facilities to do so to the people in the community. Because most of the persons living with HIV now receive their medication in the community. If we wait for them to come down to the facilities to have their blood pressure, we miss a lot of them. And that took us to leveraging case managers who are lay workers. So we are utilizing them in screening and linking these persons living with HIV back to the facilities to check their blood pressure, to have their blood pressure rechecked, and also if they have high blood pressure, to commence them on medications. We reported our stakeholders meeting also in European Heart Journal, CADOPOS. Leveraging already established system to engage people is one of the things that is very, very important. In hypertension treatment in Nigeria program, we are utilizing health educators and mobilizers, to be able to reach out to the people. These health educators and mobilizers are part of the primary healthcare system who have been involved in previous campaigns before on HIV, malaria, and vaccination. The people understand their languages. The people are familiar to them. The people believe them. So using these people to reach out to the people, and to get the people engaged is an aspect that is very, very important in scaling up our NCD intervention. Power dynamics can be very dicey and can be quite delicate, and should always be handled with care. Otherwise, any NCD intervention, any intervention for that matter, can suffer. Now, so there are a few points I want to list as we talk about power dynamics. One, to encourage power sharing, you have to think through ethics concern in an iterative way, all-inclusive way, a reflexive way, together with those individuals and groups being directly targeted by the health research. We cannot abandon those people. We cannot overlook them. They are very, very important. They are the center of the intervention. Sharing power means that locally based researchers, community organizations, and key informants are among those initiating and leading agenda setting. And this is very important. That is where things like co-creation, engaging them early is very important to know, what can work in that setting. It is important to undertake agenda setting in physical location that promote the presence and voice of everybody. And in engaging different policy workers in co-creation and informative stages, we've taken it out of our hospital setting that can be intimidating for these people to a neutral place where these people can have a voice. Furthermore, to encourage participation by community members sharing power is very, very important. It means involving groups as decision makers, not just as part of a consultation process. Their voice must count. Their contributions must count. For effective power dynamics that will lead to change in global health, it is necessary to map out the key stakeholders of a given health intervention and the relationship of accountability that's structure the entire, and that is very important. Mapping out the different stakeholders, the relevant stakeholder is very, very important. So policymakers across departments is one of the things we've tried to do in our Nigerian sodium study. When we started the study, we did not engage all these people, but along the line, as we asked questions, as we interacted with different stakeholders, we found out that it was very, very necessary. Because when it comes to nutrition, to salt, it is very, very complex. We have to engage different policy makers and different people. Otherwise, our intervention was not going to work. And you can see the different stakeholders who have engaged, from Nigerian Agency for Food and Drug Administration, for Federal Ministry of Health, Drug and Safety. So also understanding power dynamics is very, very important. In the Federal Ministry of Health, for example, in our Enhancing Intergenerational Health in Nigeria, which is called the Enhanced CVH study, we have to understand the power dynamics. We have to know that the first people we have to engage is Department of Public Health, which in a way has some supervisory role over the NCD division and also the nutrition division and family. So when we got the buy-in of the Department of Public Health, it was not difficult at all to get the buy-in of nutrition department and also family department. Now, power dynamics also in primary care setting can be quite complex. And I will exemplify this with our hypertension treatment in Nigerian study, which is an ongoing study in 60 primary healthcare facilities, and now we're trying to scale up to 5 other states. When we wrote this grant with my co-PI, Professor Mark Hoffman of Washington University in St. Louis, we actually wanted to work with 2 to 3 community health extension workers or community nurses per facilities as implementers. But when we started our formative age and started asking a lot of questions, it was obvious that without engaging people we call facility managers who oversee those facilities, it was going to be very, very difficult for buy-in of this this intervention. And you can see the publication on stakeholder perspective. That was in implementation science communications on how we engage these different stakeholders and how we got some of this useful information, which helped us refine our strategy and then made us have some of the successes we have today. Holistic mapping of stakeholders cannot be overemphasized. For example, in the managing hypertension in persons living with HIV, you have to work with different stakeholders. Some of the most important people are people that intervention is directly directed to. For example, Association of Women Living with HIV in Nigeria, NEP1, Network of People Living with HIV/AIDS in Nigeria. Then, of course, the primary care to community nurses, because we are using a non-physician care approach with community nurse, but with supervision by primary care physician, community health workers extension, volunteer workers, people we call case managers, and of course, the policy makers. And in our engagement also, we documented simply, as early stakeholder engagement lesson from managing hypertension among people living HIV in European heart children, cardiopulse. So what are the key messages as I round up? There is no recipe, and that is very important, or model in tackling the issue of people, politics, and power dynamic in scaling up NCD intervention in real world setting. There's however much potential for positive impact if people, including policy, are engaged openly and with much respect, and power dynamics is handled discreetly. These are my references. Thank you very much for listening.